Looks like it's slowed down as far as people being admitted, so I'm going to give it basically 1 more minute and then we'll get going for the evening. All right, we are officially 5 minutes after start time. I think that's enough time to allow people to join late if they're going to. Welcome, everyone. For those who don't know me, I'm Joy Houston. I am the chair of our event planning committee for IPS and the current president-elect. So I have the pleasure of introducing everyone this evening and moderating the questions at the end. So before we get started, though, and I introduce our speaker, I did want to acknowledge our sponsors. So PRMS is sponsoring this evening's activity, which is the first in our virtual series this year, The Unified Brain at the Interface of Neurology and Psychiatry. So you'll notice we're hitting on topics that are very much at that point between psychiatry and neurology. Tonight, we're going to talk about functional neurological disorders. Future topics are going to include PANDAS, Alzheimer's disease, and traumatic brain injury. So please keep an eye out for those emails and the speaker announcements. Register for those sessions. Back to PRMS, though. So we have Remy Palmer here from PRMS. So she's just going to speak to us briefly, and then I'm going to introduce our speaker.
Yeah, thank you, Dr. Houston. Nice to see everybody. I hope everybody's staying warm. I know we have a little bit of a warm spell here. It's about 70 in DC all of a sudden. So just nice to see everybody. Thank you for having us. Just a quick reminder for all of you that we do have a great Refer a Colleague program. And it's triple donation month until the end of January. I think they might actually extend that a little past January if we wanted to. So if you have any referrals that you want to send us, feel free, and we'll be happy to make that donation to Illinois Psychiatric Society or any other mental health society that you'd like that to go to. Also, for any of you that work with residents, please feel free to send them to our PRMSU website, and I'll put the link. I'll have the information sent out to everybody, as Kristen mentioned after the meeting. The great thing about that is, as a resident and fellow, they have free access to all of our risk management material, and that is invaluable to them at that time. So please feel free to send that. And I'm looking forward to hearing the topic. So thank you for your time and for having me.
Thank you. So for those who haven't joined us for one of our virtual sessions before, basically we're going to start off with our speaker and they'll be presenting. As the presentation is ongoing, if you have questions, feel free to drop them into the chat. We're going to reserve time for questions at the end though, so we're not going to stop during the presentation. And let's see. Oh, we are recording the presentation itself, but will not be recording the Q&A. So don't worry about having your question recorded if you're nervous about that kind of thing. Without further ado, I'm going to introduce Dr. Kathrin LaFaver. We are really lucky to have her speak with us because she's very much an expert on this topic. So her background is that she's a movement disorder specialist who's certified, board certified in neurology and lifestyle medicine. She did her residency at Mayo Clinic, then completed a movement disorder fellowship at Beth Israel, and then a research fellowship at NIH. Currently, her location is that she has a movement disorder focused community-based practice in Sarasota Springs, New York. Prior to that, she had a long list of leadership positions and appointments at various institutions, including time as an associate professor at Northwestern University. So right here in the state of Illinois. So got that tie there. She's also a founding member of the Functional Neurological Disorders Society, co-founder of the Women Neurologists Group, and has served on the AAN Task Force for Gender Disparity. So again, we are very thankful to have her come and speak to us. Dr. LaFaver.
Thank you so much for the kind introduction. Thank you for having me. Functional neurologic disorders is a topic definitely near and dear to my heart. So very happy to bring this to this audience today. All right, so let me share my slides. Okay. Let me see. Can you all see these now? All right, perfect. Okay, so we will be talking about functional neurologic symptoms disorder, previously called conversion disorder, and it's a large topic. So as far as my disclosures, I have served on the board of directors of the Functional Neurologic Disorder Society, as well as an organization called FND Help, which is a patient-led organization dedicated to education and outreach for FND. And the topic tonight will be brought to you under my lens as a movement disorder specialist who has led treatment programs for these disorders in Louisville, Kentucky, and in Chicago at the Shirley Vine Rehab Institute. And my talk will mainly focus on functional movement disorders, but I'll kind of branch out and kind of make the connection to related presentations. So let's jump right in, and I just want to attempt a definition for functional movement disorders, because some of you might be wondering, well, what are we actually talking about tonight? So we define functional movement disorders as one of more symptoms of altered voluntary movement control, which is incompatible with other neurologic conditions, so kind of this negative, kind of a exclusionary definition. And we'll talk more about that in a little bit later. So these disorders often present as tremor, as weakness, gait disorders, but can actually mimic any other movement disorder, and there's often overlapping presentations. The onset of these disorders is often acute. The symptoms might vary over time. We may see spontaneous remissions. These patients are often quite severely disabled from the get-go and might often end up in the emergency room and be in a high degree of distress and disability, which kind of makes the care often challenging. And on top of all this, the optimal treatment for these disorders is really not established. And of course, there are treatment avenues, but despite best treatment efforts, prognosis has often been very guarded, and these conditions are often chronic conditions and cause a high degree of disability for patients. So these disorders are by no means new. So just a very brief back into history kind of slide here. Again, there's been numerous variable terms over the years and centuries, I suppose. So we're all talking about the same idea here. So the term hysteria dates actually back to ancient Egypt and was kind of attributed to some sort of a wandering uterus in the female body, causing possibly physical illness, manifestations. And through the end of the 18th century, there's often the idea of some sort of a demon possession or spirit possession that might cause abnormal spells and so on, similar to epilepsy itself being attributed to demonic possession. And then Sigmund Freud entered the landscape, a very pivotal figure for our topic tonight. And he defined hysteria as a psychological distress that unconsciously gets translated into a physical symptom. And so that kind of relates to this idea of a conversion of a physical to a psychological to a physical symptom that's still very much in people's mind when they think about these conditions. And so, as I mentioned, the terminology can really be confusing and is not really uniform, even among neurologists today. And then mental health providers and neurology providers often speak different languages. So from hysteria, psychogenic, pseudo, as in pseudo seizures, non-organic, sort of broader terms such as psychosomatic, stress-related, medically unexplained, and functional, the kind of term I use. So it can really be confusing. And, there's lots of debates back and forth, like what is the best term to use. So the reason why neurology has kind of moved away from this conversion disorder term towards more functional is really to open us up to recognizing more of the biological underpinnings, and kind of realizing these are often not structural abnormalities, but functional abnormalities in the neurologic system. And we'll talk a little bit more about the pathophysiologic underpinnings. But one of the reasons to prefer the term functional was also that it's a much more accepted term by patients. It's perceived as less stigmatizing. So it can be very helpful, especially when initially making a diagnosis, of having a bit of a more neutral term, and then really being able to explain and explore with patients why this disease happened, what they're dealing with, and look at different avenues of getting patients ultimately better, which is our goal, of course. So I want to just pause a moment here and really talk about the scope of the problem. And I know that people listening right now or listening to this talk later might really have a different background and different level of exposure and experience with patients with that diagnosis. And I have to say that as a neurologist, me and my colleagues often see that sort of difference, and it can often be difficult to find a common language. And so common experiences that I often hear from residents or colleagues in the field is that this diagnosis is made, let's say, a functional seizure disorder, a non-epileptic event disorder, and then communicated to the patient, and they go back and or get recommended to undergo psychotherapy, and then often are met with actually skepticism by their mental health providers, and might be told by a psychologist or psychiatrist, well, I'm not so sure. I mean, these certainly look like real seizures. You should probably seek a second opinion. And while second opinions are generally not a bad idea, it's just often a problem that people ultimately feel they get a lot of differences in opinion and get kind of tossed around, and don't get actually ultimately the real help that they need. So just to throw out some numbers here, there have been several studies showing that up to 5% of patients seen in movement disorder clinic have a diagnosis of a functional movement disorder, which is a relatively high percentage. And for people with unexplained seizure-like spells that seem to be not responding well to medications, they often get referred to epilepsy monitoring units with the goal of clarifying the diagnosis, and if they truly have refractory seizures, be potentially candidates for surgical options and so on. And patients being monitored in both settings and epilepsy monitoring units around the country have about a 30% likelihood of ultimately being diagnosed with functional or non-epileptic seizures. So it's really a substantial portion of patients in our neurology clinics that have this diagnosis that is really in this borderland between psychiatry and neurology. There's been also older studies, I'm citing here, kind of referenced it below, by John Stone, done in Scotland back in 2010, where they actually did over a 6-month period, surveyed all neurologists in outpatient practices and had them fill out questionnaires to what percentage they felt that their patients had an organic versus non-organic or psychosomatic etiology of their symptoms. So they used a bit older terminology at that time. And what the finding ultimately was that in up to 30% of patients seen in neurology outpatient clinic as a new patient, the neurologist felt that their symptoms were not at all or only partially explained by organic illness. So this is often what we also label as functional overlay, or, there's kind of a combination, and we all know this, right? There's mind and body, or mind and brain are ultimately not separable. But again, just a reflection of how many of these neurologic symptoms we're dealing with are really very multifaceted in the etiology. So despite these numbers, there really is a lack in public awareness and research efforts in these disorders. They can be very disabling, as I mentioned, and pose a large economic burden on our healthcare system, as they often lead to chronic courses and chronic disability. So my next slide here is a little bit provocative, but since I'm talking to psychiatrists tonight, I really did want to highlight, the need for us to talk like we're doing tonight and have these conversations because of the underestimation of the scope of a problem. And, I don't know how active everyone is on social media, but I'm on Twitter and I do follow psychiatrists. And this is Dr. Alan Francis, who's a professor emeritus and actually retired chair of psychiatry at Duke University. And, there've been, he's very provocative. He likes to provoke people on social media and make statements of medication overuse in psychiatry and so on. And, in a discussion with neurologists, he made that comment, and this was a few years back, but he made that comment that conversion was most common, one of the most common psychiatric presentations 150 years ago, and has now almost disappeared in all developed countries. And he went on to say that this is a great example of how cultural expectations shape psychiatric symptoms. Patients now express their distress via thoughts and feelings and not the loss of physical function. Well, as a neurologist, I can only say that I disagree because, and I think what's underlying this misperception is that a lot of these patients who present with functional neurologic illness or conversion disorder are not in the office of a psychiatrist, but are in our office, are coming to neurologists, which makes a lot of sense, right? Because if you have tremor in your hands or a spell that looks like a seizure, you're going to see a neurologist. And a lot of times, as I said, the care coordination can be very difficult, and people might not find their way back as much in the mental health system, as they probably should. So when we look at demographic features of patients, we're seeing predominantly women presenting with FND. There is a common history in the background of trauma, abuse, and those can be different types of traumas or just adverse life events in both a physical sense, things like that might seem relatively minor on the surface, like an car accident or divorce, things like that, as of course also more significant history of PTSD or abuse, etc. And we often see psychiatric comorbidities, including depression, anxiety, as well as chronic pain is very common. So our pain conditions such as migraine or unexplained body pains, subjective fatigue, and also cognitive complaints, very common. What are some typical exam findings? And again, this is mostly a bit focused here on movement disorders. So how do we know they're dealing with a functional movement disorder? Well, the movements are often not easy to classify and are really not falling in the typical scope that we see with things like Parkinson's disease or an essential tremor. So there's often an overlap, a combination of different movements and variability over time, even within a single exam, as well as distractibility. So that's often very important to really tease that out on the exam. So when the patient is distracted, for example, when they talk about their history, the movements are often a lot more quiet than during the exam part, then the focus is on them. Movements can be entrained, and what that means is when people have a tremor of a certain frequency, you can try certain maneuvers where you kind of have them tap the contralateral hand, and the tremor changes. The tremor might speed up and slow down, and again, that's something we don't expect with Parkinson's disease. There often are additional non-neurologic findings, such as giveaway weakness or sensory loss and non-anatomical distribution. So it just kind of suffice to say that it is important to, of course, do a detailed neurologic exam and not sort of make a diagnosis just by association, such as, oh, this patient is depressed. This must be a functional neurologic disorder. So that's certainly not sufficient. And just to show you here a very brief, quick examples. So this is a woman who was in my office with a hyperkinetic movement disorder. And I just labeled it as hyperkinetic because it's not a tremor. It's just abnormal kind of movements. They don't look like tardive dyskinesias either. They don't have a kind of a creiform appearance. It's just kind of variable hyperkinetic movements. And then although these movements are here initially very prominent, what is seen later as I do some of these distraction maneuvers. So I have her do some movements with the hand here. These body movements, the truncal movements, the head movements completely stop and then kind of resurge again. So that would be a high degree of variability that I was kind of mentioning earlier. Here's an example of some functional gait disorders. So the variability aspect here is that oftentimes when patients are examined in a seated position or laying in bed, their leg strength is actually good. So we're able to generate full strength. But when we're asked to walk, they often drag the leg in a very exaggerated fashion, kind of the knee buckles, they're holding onto the wall. It's also kind of called wall surfing. And just, you know, an unexperienced observer might assume, well, this person might have had a stroke or a traumatic brain injury. But taking together the physical exam and teasing out that variability with a normal exam, oftentimes in a seated position, and then the abnormal gait is really crucial. These disorders don't only happen in young people. So this is a older woman who was sent to me for a gait disorder and has this kind of interesting cross walk where she's like going back and forth and ultimately was diagnosed with a functional movement disorder. I just happened to see an 86-year-old patient in my office this week. Was actually diagnosed with a functional gait disorder a few years ago after her husband died, and that did okay for a while, but symptoms had resurged recently, and she started walking backwards. So not a common symptom that we usually would expect with people who present with a neuropathy or Parkinson's disease, you know, so kind of all of a sudden changing direction, walking backwards. And those are, you know, pretty typical presentations for functional neurologic disorders. So just to summarize some of the key points for the clinical presentation, from a neurology perspective, there's no question that these disorders are very common. They are more frequent in women, but can certainly occur in either gender, children and elderly patients. Variability and distractibility are some of the key symptoms we're looking for in making the diagnosis. And comorbidities are very important to recognize, not just to help as supportive features for the diagnosis, but it's, of course, also important as far as treatment planning goes. So pain, depression, fatigue, very, very common symptoms. And I'm not going to go too far into the specifics of making the diagnosis, but suffice it to say that in these past 10 years, there really has been a lot of thoughtful people putting together sort of key articles and defining what are really the phenotype-specific characteristics we're looking for that make this diagnosis of a functional neurologic disorder. You know, for functional or non-epileptic seizures or spells, we have kind of the EEG, ideally during a spell, to be a main key feature in making the diagnosis. We don't have the same electrophysiologic tools for gait disorders or tremor, but there have been just phenomenologically well-defined criteria that have been validated, and it's no longer correct to say that these disorders are really a diagnosis of exclusion, but then we actually define these typical features, including the variability, the distractibility of these movements. This is really a diagnosis that can be made with confidence and communicated to patients, and not kind of remain a chart diagnosis. And if you don't mean what I'm talking about, in the past, and I hope this is a thing of the past, there often used to be clauses mentioned in patients' chart. Oh, there's some sort of a functional overlay, or kind of terms used to indicate to other physicians that they don't believe an organic diagnosis is present. But this was never really explained to the patients. And I think that communication piece is really, really important, so patients understand their diagnosis and can hopefully move forward towards treatment. So I mentioned I will primarily focus on movement disorders, but it really is important to recognize that these patients rarely present with a single symptom, and much more frequently with a whole symptom cluster, right? Taking a patient with an abnormal gait disorder, there's often many other complaints, including the chronic pain and cognitive complaints I mentioned, oftentimes weakness, oftentimes also things such as speech or swallowing complaints, like a globus sensation is often very typical for functional swallowing disorder. But even bowel and bladder complaints can be seen. And underlying these things are often anxiety, dissociation symptoms, autonomic dysregulation. And when we try to kind of look at the root level, so what really is underlying these symptoms and would count more as a risk factor for FND. And I had already mentioned negative life experiences, trauma, neglect, emotional dysregulation, maladaptive coping techniques, loss of locus of control. So there's many more factors that are now recognized as risk factors for functional neurologic disorder, although we still have more to learn about sort of a psychosocial background for FND, especially when it comes to how can we really help people long term to prevent these relapses or symptom relapse. So I mentioned that diagnosis is really crucial for patients to move towards recovery. Generally should be made by a neurologist because, as I mentioned, a detailed exam evaluation is certainly important. After that evaluation, the diagnosis needs to be made very clear to patients, explained in terms we can understand. It's really important to avoid the patient feeling judged or dismissed, and that is very common. Indicating the belief in patient symptoms is really important, and it can often be helpful to demonstrate how the diagnosis was reached. So if there is a significant variability in the exam, to point that out and essentially explain the background that brain pathways that control movements are in a way glitching at times, right? And that sort of underlies their symptoms, and that the symptoms are not voluntarily produced, so to speak. Because many patients feel accused or might kind of mistake this diagnosis for an accusation of malingering, which makes them then very, difficult to have a therapeutic relationship. So as I said, this shouldn't be purely made as a diagnosis of exclusion, and it's important to emphasize to patients the potential for reversibility. There certainly are some diagnostic pitfalls. So sometimes things can look really bizarre, but do have an organic background, so most certainly, and that can be as simple as Parkinson's-related dyskinesias. So it goes kind of back to having experience, having clinical experience, is definitely important in making the diagnosis. Some exam findings are not as specific as they were maybe thought or made out to be. So some of you might have heard the term la belle indifférence, so kind of a French way of saying people don't care about their symptoms. And in a way, I guess it goes back to this conversion concept where, you know, the thought was, well, if people don't seem distressed by their symptoms, it might be sort of a protective sign, you know, to kind of help with dealing with stress. But that has actually been looked at in studies and has really not been found to be a good differentiator for the specific diagnosis. Other things such as give they weakness, so meaning kind of weakness that is collapsing, might also happen when someone is in pain, right? So just kind of looking out for potential confounding factors is certainly important. And then lastly, it's also important to recognize that functional neurologic symptoms can coexist with other neurologic disorders. So at least 10% of people with non-epileptic seizures also have a comorbid diagnosis of epilepsy. And so again, the expertise of a neurologist and taking all the data into account of EEGs, et cetera, is certainly important to not misdiagnose. And for that reason, it's typically also recommended that these patients remain in neurologic care. So even after the diagnosis is made, and let's say they are recommended to undergo psychotherapy, it is generally very helpful for the neurologist to stay involved and see them periodically. And one of the reasons is to reassess, you know, over time and, you know, make sure no other symptoms surface, and also help with co-management of things like migraines, for example, that are very common in these patients. And lastly, functional disorders can be precursors to develop into other things over time, such as Parkinson's disease. So there's a nice case series by Dr. Alberto Espay, who's a Parkinson's specialist at the University of Cincinnati, and he has kind of collected a few cases that were convincingly diagnosed as functional tremor and then over time actually developed into Parkinson's disease. I did mention the kind of differential diagnosis to malingering and factitious disorders, and I'm sure you're all very aware with these terms. But yeah, so suffice it to say, functional neurologic disorders are not malingering and are not factitious and are really involuntary, which really differentiates it from these two other conditions, which are not, you know, medical conditions per se, but really symptoms that are intentionally produced for secondary or primary or secondary gain. So what have we learned about the pathophysiology, about the background? Why do people develop these symptoms? So the story is certainly complex and is still evolving. This was a nice article from a few years back, published in Psychosomatics, and really kind of looked at the literature and kind of reviewed what are some of the biologic predisposing, precipitating, and perpetuating factors, what are the psychological factors, and what are psychosocial factors. And I'm not going to read you the entire table, but yeah, I do find it very interesting and important to really keep in mind that there is a large variability between patients, and sort of this mold of, oh, this is a woman with abuse background. That is certainly not true for everyone. and so that's really important to keep in mind, because as I mentioned, these things can certainly happen in men, can certainly happen in old age, can certainly happen in people who might be really stunned to hear about this diagnosis and, you know, tell the neurologist, gosh, I never had any trauma in my life. I'm doing fine. You know, so I think it's just important to keep an open mind. And even if there are factors in the background, it is really helpful to, you know, in a way, kind of confront people and, you know, kind of, I know this is not really a popular concept in psychiatry anymore, but, you know, look for repressed memories and kind of be convinced that everyone who has this has some sort of a trauma in the background. And again, these things can be much more subtle, but are very common things, for example, are people who have been lifelong caregivers, you know, for children, for spouses, and then get relieved, or the spouse dies and they feel incredibly guilty. So there can be a lot of psychological factors that are not necessarily that Freud kind of simplistic explanation model. So the popular Freud, and as people often kind of come to this. So it's just good to stay humble and have an open mind, but have a really detailed conversation with patients about their life history, about the preceding events. I think can be very fruitful, and certainly very, very helpful in the care for these patients. So for anyone who wants to dive deeper, there's an excellent article that I would certainly recommend. And so what are the underlying brain pathways now involved with producing these functional neurologic symptoms? So how is it possible that these movements that are often so obvious and so disabling are actually involuntary? And that is a really interesting question, but lots of research has been looking into in the past decade or so. So again, in the scope of this talk, I don't have enough time to dive into sort of research studies in too much detail. So I'm mostly going to direct you to a wonderful, actually 4-paper series published in CNS Spectrums in 2020. They were written by a really very multidisciplinary panel of neurologists, psychiatrists, therapists. Really was a very wonderful collaboration effort of many prominent people in the field. And so the pathophysiology article essentially made this conclusion that there's many different brain pathways involved in producing functional neurologic symptoms that encompass attention pathways, emotional processing, sensory motor function, and bodily awareness or interoception, which is a really important concept. And at the key, or what it all kind of boils down to, is often the prediction of what's going to happen. So the prediction of movement is not working out correctly. And so this feedback loop gets disrupted and leads to a sense of agency in people. And so kind of boiling it down a bit of a different way, when we look at, well, how do we control movements? How do we plan our movements? So we have our prefrontal areas as well as limbic areas that are involved with movement planning, that goes to the premotor areas, goes to the primary motor cortex. And then the nerves, the signals travel down through the spinal cord, through our nerves to actually execute movement. But what's equally important is that feedback loop. So when movement happens, the feedback loop through the sensory system gets back to the brain, right, to the parietal areas. And then there's comparison happening. Well, is the movement that happened is that the same that was planned? And through that feedback loop, adjustments are being made, right? And this is kind of a constant background loop that is going on. Then we all plan and execute movements. And so what happens with FND, as I was mentioning, because the whole pathways involved with agency can be affected, the comparison between planned and executed movement is not working correctly. So the predicted outcomes are not what's actually happening. And so it's not the complete explanation, but it is one explanation that has been shown in imaging studies. So functional imaging studies have been looked at and found that areas involved in the self-agency, involved with the limbic cortex, are functioning at a lower level than patients have these functional movements. And so it's really exciting, and we had talked about it a little bit before the talk, that we have actually more evidence now to say, look, this is not your fault, because a lot of times people feel, oh my gosh, feel very guilty. They're bringing this on themselves and they just need to stop it. But it's not so simple. And what we can tell patients is, well, there are changes in your brain pathways that make you more likely, make you more susceptible to developing disorders. And the exciting thing is that things can be changed with the therapy. So another review paper here from David Perez group, he's at MGH in Boston. And there's kind of a summary to show all the different areas that have been found to have either structural or functional changes in FND. And so it kind of goes back to the diagram I had on a few slides ago, that it's really not a single area, but really kind of a network of movement planning that is not functioning properly in FND. And I'm happy to actually send people the papers if anyone wants to have a look at that. But in the interest of time, we'll switch gears a little bit and talk about the treatment, right? Because ultimately, for anyone here on the call who's a clinician, ultimately that's what we want, right? We want to help patients. And unfortunately, there are some unique treatment challenges with FND. So I mentioned already that there is a high stigma associated with the diagnosis. There is misperception by the general public and healthcare providers, and patients might be perceived as malingering. Patients might even be perceived as malingering by their own family. So that creates often big problems, and education is really important. It's not always so clear who should plan and oversee treatment. So do these patients belong to neurology? Do they belong to psychiatry, right? There's a lot of unclarity. And this all leads to poor access to treatment resources in many areas in the US and around the world. This is a nice paper in that CNS Spectrum series that looks at stigma in FND care. And this was a survey to FND patients, asking them about their lived stigma from different healthcare providers. And unfortunately, the neurologists rank the worst. So those that are often the first line of assessment for these patients. So there's kind of close to 40% that patients say they perceive extreme stigma from neurologists. So I'll just leave it at that. So we have to do better. Mental health providers are scoring better here, but in my own experience, what I often see that patients that I share with psychologists and psychiatrists, that the FND diagnosis is not really acknowledged, So you don't have to feel too good about these numbers here, because, part of it, what I feel at least, that the diagnosis might not even be recognized. I often see, this patient has tics, but it's not really recognized that they're actually functional tics, and it's not a diagnosis of Tourette's syndrome. So stigma is important to recognize because, of course, it affects patient care, it affects treatment outcomes, the trust in the medical profession as a whole, and ultimately lack of access to care. So we definitely have to do better with that. Now, with that being said, what treatment is available? So certainly psychologic treatment strategies, so cognitive behavioral therapy is one of the best researched for this patient population, but also other psychotherapy modalities, physical occupational therapy, multidisciplinary rehab, medications might certainly have a role, especially for comorbidities. Hypnosis is sort of an interesting research avenue taken by a few people. Transmagnetic stimulation, placebo treatments. So, whenever there's a list long like this, it's not so simple, right? It's not a kind of a simple one uniform answer for everyone. So John Stone and Ellen Carson are kind of pioneers in this field. They're a neurologist and psychiatrist team from Scotland. And they actually got an official treatment guideline in the Scottish National Health System, and they propose a stepped intervention, which makes a lot of sense. So for people who just get diagnosed or might have milder symptoms, it might even be enough for a primary care person in or a neurologist to give a diagnosis, have a very simple brief intervention, and release people back to primary care. Now, of course, the patients that we see often in the inpatient services in the hospital, in more specialized clinics, are often much more disabled and do benefit from more specialized, more complex care. So I'm just going to very briefly mention, and in the interest of time, I'm actually going to skip over some of these slides. So there are some randomized controlled trials showing some benefit from physical therapy and multidisciplinary therapy. There is older studies looking at cognitive behavioral therapy self-guided help, and there's actually a published treatment manual that can be used for that purpose. Physical and occupational therapy, again, I'm not going to go into too much detail, but the idea is to really help people to reestablish normal movement patterns. And for this to work, it is very important that the therapist understands the diagnosis and the patient understands the diagnosis. And the strategies are very different from sending someone to a physical therapist and they're going to focus on strengthening their muscles, which is not the problem, right? The problem is in the brain. So for these strategies to work, people actually need to understand the diagnosis and use FND specific therapy principles. With that being said, so this was a pilot study done in the UK, and randomized people with functional motor symptoms to FMD-specific physical therapy over only 5 days. And they demonstrated a 72% improvement rate at 6 months. So that's quite impressive. With that being said, these patients were highly selected, very high dropout or inclusion screening failure rates for people with comorbid depression, for example, which we have just discussed, but that's very common. So physical therapy alone, not going to be the answer for most people. Inpatient rehab for more severe cases can be very helpful. And I'm just going to show you one example from my previous practice in Louisville. So this was a 20-year-old football player, very active, started having some back issues, and then had kind of acute onset leg weakness after a football game, developed leg tremor, was a bit of a medical mystery, was ultimately felt to have Guillain-Barré syndrome, although his workup was actually negative, was sent to a rehab facility. And by the time he saw me, he was in a wheelchair. He was kind of walking with these crutches, and then was told by the rehab team at some time, you don't really have Guillain-Barré syndrome. This is really a functional movement disorder. And this was quite devastating, because they kind of felt, gosh, all of a sudden they're like abandoned, they're being kicked out of that rehab facility. And he was quite disabled, as you can see here. So we did admit him to an inpatient rehab course in the Louisville Fraser Rehab at the time, and within a single week, this young gentleman went from being in a wheelchair to being back at the playing field. And I really love his story, because he went really public with it, and they did an article about him in his local newspaper where he kind of really openly discussed his recovery process. And it's kind of the ideal thing, right? If patients then act as actually educators and kind of, amplify the visibility for these types of diagnosis, and hopefully help in dissolving the stigma as well. So just to kind of summarize the treatment approach, it certainly is best if a team works together, right? And better that the exact team players, not everyone needs everyone, but certainly a neurologist, mental health providers, oftentimes social workers, therapists can be all very helpful and have roles in them. So does treatment change the brain? It does. This is a pilot study that we did in Louisville with some of these patients before and after treatment. And we saw changes with the amygdala connectivity before and after treatment when people did a motor task in the scanner. So we saw before treatment, they had a stronger connectivity with the ventromedial prefrontal cortex, and after treatment, there was a stronger connection with the premotor cortex and the pre-SMA, so possibly a stronger planning component to these movements. There's another nice paper from Alberto Espay in Cincinnati, and they looked at connectivity changes with the cingulate cortex before and after cognitive behavioral therapy, and found changes with decreased cingulate after activation after therapy. Granted, these are fairly small numbers, especially for functional imaging studies, but it's exciting to see that research is happening in these areas, and we can kind of more and more try to look at the underlying brain correlates for the changes we see. Emerging treatments, I kind of mentioned that briefly before. So if you're really assuming, well, there are these areas like the areas of self-awareness in the parietal cortex, of self-agency that might be affected, well, is there a way of maybe strengthening these or affecting these pathways through transcranial magnetic stimulation? And that research is still very much in its infancy, but might really hold promise for the future. So with that being said, there still are many open questions as far as the best treatment setting, who really needs what kind of therapy, in what setting, in what length, but the most important thing is we all need to kind of step up and offer treatment, right? Because it's very difficult for people to even find mental health professionals who are actually advertising themselves as actually experienced in these conditions, and so that's often a challenge. In the ideal world, we would certainly want to see more randomized controls trials for treatment and especially long-term outcomes. So with that, I just want to summarize a few points. So although these disorders are challenging to treat, patients have the potential to restore normal function. And I think that should be very exciting for all of us, right? And since I'm the first in this series of talks, right, I heard that there's going to be more talks about Alzheimer's disease and traumatic brain injury. So I've been always very excited about this patient population and, stories like a football player that really go from wheelchair bound to normal function. And I think that should be exciting to all of us to have the potential to making such a big difference in someone's life. If people are more interested in resources, so again, you're all going to have access to these slides. There are websites with good information for patients. It's also, I find it very interesting to follow some patient blogs. These are some very good examples of patients who share their stories and are very good advocates and provide helpful resources for other patients. This is that CBT book that I mentioned. There's also a workbook for non-epileptic seizures by Kathrin LaFaver, which is excellent. I had the pleasure of co-editing a book on functional movement disorders that's more geared for healthcare professionals. And lastly, if anyone feels inspired now to dive in, the 5th meeting of the Functional Neurologic Disorder Society is coming up in Italy in June. So if anyone's looking for an excuse to travel to Italy, here is your chance. And with that being said, thank you everyone for the attention, and I would be happy to take questions.
Thank you so much, Dr. LaFaver. So I do have one question that was sent to me in the chat. So you mentioned, of course, the role